You can begin, Claire.
Morning, everyone. It's lovely to see faces. Actually, it's quite nice to see faces, but I understand why some people don't want the camera on, and that's fine. But it is lovely to see faces as well. So welcome to the first of the sort of new health forum for the National Working Group. We wanted, I think Sheila will talk about why she wanted to relaunch it, but I'll just really want to say hello and tell you quickly about me, and then Sheila will move on and tell her about her and sort of the lay of what we're going to do for the next hour and a half. My name's Claire Beecher, so I'm going to chair this with Sheila jointly. My background is I'm a paediatric nurse and health visitor. It seems like a long time ago, 30 years ago I did my nurse training, and like we've all been on this acute for quite a long time, and then came into community about 15 years ago, worked very shortly, not for very long, as a health visitor, and then went into a named nurse for children looked after children, and set up a service where part of our remit was about supporting children who've been exploited, because it was quite a small authority. So we did that as well as looked after children. And in the last year, I've been working in a much bigger authority where we have a standalone child exploitation hub, and part of what we're going to talk about over these sessions is about what some of the things that maybe we've learned along the way, and actually in discussion with you about what you want to talk about and things that you've learned along the way as well. And actually I think what me and Sheila have been really sort of amazed at is how many people actually want this forum and that want to talk about it with other people to learn what's working well for them, or maybe is what's they're struggling with, and how we can all sort of put that together and gather some information to maybe unbreak some of the things that have got a bit stuck. So that's me, that's my background. It's lovely to see you all. I'm really, really proud of this, about what we're going to be doing moving forward, and I'm really looking forward to seeing you all and having a discussion. So I'll move on and let Sheila do the next bit.
Hello, for those of you who don't know me, I'm Sheila Taylor. I'm the CEO of the NWG Network. I've been involved with child sexual exploitation and tackling the issues from a practitioner level since 1998, when we called children, young people in prostitution. That whole journey that we've had around recognising them as trafficked victims and a whole host of things as we've gone on. We previously had a health forum, and it was chaired by Dr. Paul Kirkley, who was a retired GP who had a particular interest in this area of work. It was a very, very popular forum for us, but when we lost our health lead, so for God's sake, don't give anybody a sabbatical, because if they go off travelling around Russia and doing nice things, they just don't come back. They ring you up and say, oh, this is really nice life, I'm not going back again. So you know, if your positions of management, seriously think about sabbaticals. And when we lost our health lead, we didn't really pick the health button up as we should have done, and that was largely due to funding for us. Dr. Paul Kirkley, when he was with us, did a report which was, if you shine a light, you'll probably find it. I think it's still relevant in many, many ways today. And Cheryl, who's part of my team and is here in the background, will put a link to that Shine a Light report into the chat for you so that you can see it. The way that our forums work is that we do a little bit of an introduction, and then we, just bear with me. We do a little bit of an introduction, a welcome for everybody. We do then the sort of national updates that are relevant to health and relevant to the area of child sexual exploitation, labour, county lines, any of those things. And then we move into usually an hour's worth of a theme, which is what we want to talk to you about. What themes do you want to see? I don't want to cap it. Quite a lot of our forums are capped at 25 people so they can allow discussion. I think we've got far too much interest in this. So I want to allow everybody to attend, and the way that we'll network and the way that we'll have discussion is in breakout rooms. We will take notes from all of those breakout rooms and bring the key messages back through either a vlog or a blog following the event, so that you've got what everybody's spoken about in each of those breakout rooms. A little bit of feedback session coming out of those breakout rooms, and then moving on to, okay, what theme do you want next? What are the current issues that you're struggling? So there's a bit of a debate. So I hope that forum fits well for you all. And if so, and of course, there's always the opportunity to say, can we change it to look like this? Yeah, I would really welcome everybody using the chat to stay muted and use the chat. If there's a question comes up, please, we'll ask you to unmute yourselves and have that conversation, what have you. Claire's going to manage the next bit, but strangely enough, we have already had, this morning, we've already had a request for some assistance, which we'll come into when we get down to that part of the agenda. So welcome everybody, thank you for attending, and we look forward to seeing these on a regular basis.
Brilliant. So I thought we'd just do at the beginning, just understand what the service that I currently manage looks like, just because we've been on a journey, like we all have, around child exploitation, which sort of underpinned was a review of our service, which was quite poor. And actually what we put in place now to look at what we want to deliver for children and young people. So sometimes it's quite nice to share other people's journeys that is not yet complete, but actually is going in a much healthier and positive direction for young people. Currently what we have is for the health bit, because I think that's the bit that we need to be talking about. And I think sometimes, I was saying to Sheila, sometimes we get a bit lost in health, because generally child exploitation, the service is managed by the local authority, and actually that means that social work and social care are very much driving it, and that's fine. But actually health is really important, and our health role in that multi-agency hub is really important. So our current practice, we have two, I was going to say full-time, they're not. We've got one full-time band 7, one 30 hours band 7 who has recently joined our service, and we've got a band 4 administrator as part of our multi-agency response to child exploitation. So they are co-located in the service, and the whole of the service sits together, including the police, which was a bit tricky because of their IT, and they're not quite there yet, but they are coming. So the whole child exploitation service will sit together, sort of round a table, so to speak. And strategically, that's what we wanted, following the review of the service, which clearly said to us that actually we were still working in silos. Everybody was working well, but we were working quite individually, and we weren't doing some joined up working. So one of the things we've done is we've put everyone together round a table, so the whole service now sits together. The second thing we've done, which has been built and which you may recognise in your services, that we have a daily RAM, a risk assessment meeting daily, and everyone from each of the main services is to attend, where we can discuss up to 6 cases, around about 6 cases. It's a weighty piece of work, that, and it's very time consuming actually, because actually when you think about it, and I think for commissioners it sometimes feels a bit frustrating, because actually what you want is for people to go out and see young people, but actually it's a really useful multi-agency forum on a daily basis where you discuss the impact of child exploitation on a child, and you assess their risk and who and what are they doing about it. We've also got.
She doesn't need a post, she's just trying to watch the television.
Oh, sorry. Are you all right? I think someone came off mute. The other thing we've included as well is the voluntary sector. So the voluntary sector have supported the 3 main agencies, and we have 2. We have Breaking the Cycle and we have Turnaround and Trusted Relationships. And both those work with young people, but they also attend the multi-agency risk assessment meeting that's daily. Following the findings from our thematic review, there was a list of 10 actions that we were sort of raised to look at. And I think you will, some of you will recognise some of these actions. I've written them down because I can't remember off the top of my head. But we do. So we talked about, so one of the main ones, which is the one I just talked about, was about we need to work together. We need to sit together and work together and understand each other's roles and how we fit together, how that jigsaw fits together, because only when we fit the jigsaw together do we get the whole picture. So in some ways we're like, tick, we've done that. We are now all sitting together in the same room. It also talks about a system-wide approach. And I think in health that is quite complicated because health have many systems. And when people don't sit in health, they just think the NHS is just one thing with one system. And we all know it's many things with hundreds of systems that generally don't talk to each other either. So we are the health representative in the team are access to lots of health systems. So they can access the mental health system, the sexual health system, the system 1, but it's, you know, so they can access the health systems they need to be able to access to share relevant information. And that was really key, because you don't want the little bit that you might be able to access as a health visitor on system 1 without actually the quite important bit about sexual health. The thing that came out of the report clearly is not recognising, I mean, some of the lessons we've learned are you will just go, what, you didn't know that? Of course we knew it, but you know, when it's written down in black and white, you go, oh, okay. Recognising drugs and alcohol are used as part of the grooming and coercion control of a victim. Of course we recognise that, we all recognise that in this area of work that we're doing, but actually it was quite a start that we might recognise it, but actually there wasn't enough evidence to show that actually we were recognising it, but what were we doing with that information? So they are part of the service that we now have as well, and I think that's a really important one. That children who've got a disability are more vulnerable. I mean, again, none of this is brain surgery, and none of this is what you won't recognise yourself. It's just about what I'm trying to bring to you, our little flavour of the journey we've been on. Of course, we recognise that children with an extra need, whatever that need may be, physical, mental, or learning need, are more vulnerable. But it was written down clearly that we weren't recognising their added vulnerability. For looked after children, which I know and I understand because that's my background, that moving children does not make them safe. Moving children often increases their vulnerability. Sometimes we have to move children. Sometimes they've got stuck so much in child exploitation that the only thing you can do is move them. But actually what we need to recognise, and what we recognise, is that actually just move.
Claire, I think you've gone to mute. Could you just unmute yourself? We just missed that last sentence.
I was on a flow there. Sorry. Sorry. Just stop me. I've had 3 cups of coffee this morning because I was slightly nervous. Stop me if you want to ask a question. Education was key. We didn't have an education person around the table, and we now have a full-time education. We know that children who remain in education are safer, because from 9 till 3, we know where they are, we know they're safe, and actually, rightly so, that's exactly where they should be. The impact of mental health on victims is lifelong, and what are we as health going to do about that? So we might deal with them when they're children, but the impact in the adult services as well. What are we doing to support young people who've been victims, not just as children, but through to the adult services. And what we've done is we've put together an all age exploitation strategy subgroup that feeds into the partnership and the board, because we've recognised, like we all know, like I said, I keep saying, you'll know this, none of this is new to you, I'm absolutely sure. But actually what we've tried to do is, when you see it in black and white and realise that we're not evidence or showing inspectors that's what we're doing, we've got to evidence and show this. So that's what we did. Children who become parents, children and then have their children removed, and that's what happened in a lot of the cases. So in the review, half the victims became pregnant, and of those, significant amount of them had their children removed. What are we doing to stop that? It's happening again. And where can we evidence? And again, we've now got many more safeguarding midwives than we had before, because actually what we needed to show is that actually we're recognising right when we found out about the pregnancy at whatever age that we need to be starting the work there. We need to be starting it before in schools and in the 0 to 19 service and in health visiting and school nursing. But you know and I know there are not loads of those anymore. So actually, what are we doing in our service then to support children and young people? And the one thing which I know I think Sheila might be mentioning is about perpetrators. And, you know, and people get uncomfortable about it and they're not sure. But actually, why are these people doing it in the first place? Because it's almost like we're crisis managing this. We're trying to manage, and actually you wonder whether we need to take a step back and actually look at what is the perpetrator and what is happening. We don't want their voice, but we need to understand how they became perpetrators. So that was our summary of findings from the review that we had, that we remain on this journey, but actually we have learned a lot along the way. I think you'll recognise a lot of the stuff that I've talked about, and you'll know it anyway. And what I would say, the key thing for me, particularly, has been about the co-location and the daily RAM. And they're very time consuming and they're quite expensive, and commissioners need to be on board and they need to stay on board. So you can't, it's a long-term plan. This isn't a week or a month. This is years of being able to support children for today and tomorrow. That's what we are currently doing in the service that I'm managing. Day-to-day wise, so what does that look like for health? So the daily risk assessments is what the two health practitioners share those between them. So one of them will go to the daily risk assessment, the RAM meeting, and the other one will gather information or go see young people. We flag, so we flag their risk, and that's what part of our administration is doing about flagging. I'm just trying to, I've got lots of notes, ladies, and gentlemen, you'll be glad to know. Gathering health information. And the other thing that I think we should be proud of as nurses is the fact that generally people like us. Generally, young people will talk to nurses more than they might talk to a social worker or more than they might talk to a police officer. Generally, they recognise, and we're very lucky in health, that actually the community that we serve generally quite like us and think we're useful and might be able to help them. So actually, we do lots of work with young people, and we have a drop-in and we have a group session, and we're building on that as well. So how can we get young people to become peers and support other young people who might be going through that process? So we're on a journey like we all are. We've got a long way to go. Just wanted to give you a flavour. And now Sheila's going to come in.
I was just going to say, we've got a question here that says, what would you identify in terms of positive outcomes from the service?
So we have a multi-agency child exploitation meeting, and we don't have key performance indicators because it's still quite new. So in health we have our own, in education they have their own, in social care they have their own, and what we do is on a 6-weekly basis we come together as a multi-agency child exploitation. We have a strategic meeting where we look at the strategy and we make sure that the information that's shared is being fed up to the all exploitation subgroup and the board. and that it's meeting the strategy, but also we at that meeting we have strategic and we have frontline practitioners at the meeting, because the other thing that we get stuck on is sometimes we get stuck on a case. So we get stuck on a case and we can't move it on, or a practitioner gets stuck on a case and they just have tried all sorts of ways to move a case on and they can't. So they will bring it to a strategic meeting where there are the strategic leads. And actually, it's really important. And the chair is someone senior in social care, and she's brilliant, because what she says is you have to all attend. And this is important. I don't want to know that you're in court or I want you signed up and at this meeting every 6 weeks, and there's no excuse. I mean, really, because actually, if it was your child and there would be no excuse for you to not try and think with other professionals how you can make a difference to this child's life. So actually what we do is we strategically as well look at what services are available. Do we need to fund something to make a difference to this child, to move them somewhere, or find a very specific individual service for this one young person that might make a difference? So that's how we and we share that with an annual report as well. So we have an annual report that goes out. So we have a 6 weekly MACE with reporting from all agencies and an annual report that goes to the board. I think I mean, I could talk for hours, and frankly, you might all drop off. So Sheila, I might just hold my breath for a minute.
Okay, thank you. Thanks. And there's a comment there from Catherine that says in Greater Manchester they have a multi-agency complex safeguarding hub in each borough, because of course you've got lots of boroughs up there, haven't you? And the majority are co-located in police stations. They all got a specialist nurse. And that each one has a slightly different role. So I think it at some point or other it might be good to hear from that service.
Absolutely. Yeah, it sounds great.
Yeah. I was going to cover more about the sort of national trends and things that we're seeing coming through that are the issues around the children, not particularly around health, but the issues around the children. And these may well become themes that you want to do a little bit more in depth as we go. So things that are currently discussed a lot within the office and and bear in mind that we work across all disciplines, culture and attitude around some of these young people, and how that really has to change. Some of it's got to be systemic change, and underneath all of that, the use of language, which is key. I'll ask Cheryl if she will pop into the chat the Making Words Count, which is something that we did with Ramana Farouk, who's a psychologist working, psychotherapist working in this area of work with children and young people in residential settings that are victim. And I think that's going to grow. That piece of work around language is growing all the time. It's our most used, most requested training is where we do a 2-hour training online about the use of language and how we refer to young people. I actually think health are a little bit further forward with that than, say, police and some areas, but there's still lots of things, like, for example, when we talk about looked after children, and we talk about care homes, why don't we just call them homes? When we talk about staff going on annual leave, why don't we just say staff going on holiday, so that the environment that the children and young people are living in feels more like a home environment rather than a commercial commodity, and things like that. So it's quite a lot around language that we try to tackle. One of the bigger things that we're working with at the moment, and this is one link that I have got ready and prepared, is transition from those young people that are moving from children's services into adult services, and that massive cliff that they drop off. There's an area that's done a lot of work around this, a health, so it's a health practitioner that's been appointed specifically to deal with the health side of that transition from children to adult services. And Steve, who's our link into all that transition work, really keyed up on transition and children and adult services, did this little bit of a question and answer session so that he could ask the nurse there what she was doing and how it had come about. So it's about 15 minutes long, is it, Cheryl? Something like that. It's about 15 minutes long, so not too long, but you may decide that you would like to ask her to come along to a meeting to quiz her more about it as time goes on. Trafficking and the use of the NRM is massive for us. The NRM is most health workers are first responders. And they don't know. Oh, they're not first. Actually, I was corrected the other day as well. Do you want to, Catherine, just unmute yourself and go on, correct me.
Health are not first responders for NRM, so we're reliant on referral into the local authority or the police. We can't make those referrals.
You can't, yeah. Okay, thank you. You could originally, but I think, yes, with this new system that they've got, that and somebody in my team corrected me the other day and I should have remembered, but I didn't. But the use of the NRM and its benefits for the young people are totally misunderstood or little understood. So I think that's a big thing. We've got 2 members of our staff that used to belong to the counter trafficking units, so they've dealt with lots and lots of cases. So that may be a theme that at some point or other that you want to pick up. Valuing parents as valuable safeguarding partners. That's a particularly strong piece of work for us at the moment. There are a lot of multi-agency boards looking at how they involve parents as valuable safeguarding partners. And we do have a benchmarking tool within our membership site for that. So anybody that's a full paid member, you can access that. And Cheryl, I think you just go to the link, don't you, Cheryl? You just go onto the website and put that in. And that's proved to be really useful for people to benchmark their own service about how they engage with parents. So that might be something that you want to look at. A real emerging theme that I'm working on with the Lucy Faithfull Foundation and the Mary Collins Foundation is the indirect victims of sexual offending. Now, in April 2020, on its own in the UK, 8.8 million attempts to download abusive child images in the UK alone. And where that bubble is, you know, that it was a long time for children and young people to be cut off, if you like, from lots of key workers. I think there'll be a lot of online disclosures over the next year or two about about their situations. We know that the National Crime Agency has a big bubble of cases that they're investigating, some that are waiting in investigation because the numbers are so great. So I think that online and the pandemic, the impact of the pandemic is going to be a big issue for us going forward. If we want to look at that, if we want to look at the online side of that, that's fine. The bit that we can use Mary Collins and various people to bring them in as partners to talk more about what that is. The indirect victims for me are the moment that, and I'm going to say partners, but the majority of the offenders we've got in our data are male. So the moment the knock on the door happens, what that parent faces when they have got children in the house, and the impact and the trauma and all of that goes with it. So we're just in the process of developing some guidance, some leaflets and some resources, and we have all the major agencies, so the Home Office, the Department of Education, the Department of Health, NHS England, Public Health England, all of the big bodies, national bodies, on an advisory panel in that piece of work that we are developing. So do keep your eye out for that as it starts to gain momentum. There's a big thing for us, the gap between strategic and operational delivery, lots and lots of strategies. How does that implement on the ground? And that's a big piece of work for us. We go into a lot of areas and do help people to look at their operational delivery against their strategy and pathways and where they might be falling down, purely from the basis of a young person. Multiple exploitation, you know, I think we've got a tendency to concentrate on sexual exploitation and county lines. There isn't much focus on financial exploitation, labour exploitation. Organ harvesting is something we're beginning to see in this country. All of those things are part of the exploitation and that we should be considering. And when we look at young people that are exploited, they often fit into a number of those categories. We're not terribly skilled up on some of those areas of work. We tend to focus on that county lines and that. I know I was part of Operation Golf with Colin Carswell a number of years ago, which was really, to be truthful, a Fagin style operation where they had got several hundred children all over the country, this organised group pickpocketing and stealing to order. And that's not gone away, but that benefit fraud and that sort of type of exploitation doesn't really feature much in people's conversation. Then I'd look at one of the big things that we're looking at. We're very lucky. When I started, nobody was really engaged in this, but then we did Operation Retriever and police got on the bandwagon quite quickly and operations started to begin and develop. Children's Services came along following that and health after that. And I think health has been, it's been harder for health to join because of the fragmentation of the services. There's no one place in health that you can go to kind of plug in. I think it's getting better with the multi-agency hubs, but that was certainly a difficulty in the beginning. And then if you think about all those peripatetic services like faith, sport, how do they find a pathway into statutory services if you're a sports football coach on a Saturday morning and your day job is an electrician and you don't even know what the word safeguarding means? So there's a big piece of work goes on with us around those peripatetic services and how they might find a pathway and how they might talk to services. And that's twofold: how to raise concerns and particularly a lot of those peripatetic services are a diversion and a therapeutic way out. They need to be seen as positive activities, but we need to make them safe so they're not further traumatized when they get in there. The impact on victims, that's interesting because I have a parent that I've been involved with for a very long time. In fact, she's the reason that I do the job that I do. The impact on her and her daughter, who was exploited from the age of 12 and is probably nearly 40 now. We can talk about that long-term impact and what it means and what that young person, that particular young person, went through. And what we're hoping with that parent is that we can do a series of she needs to remain anonymous, but a series of sort of 7 to 10 minute videos or podcasts that means she can talk about what those different things were for her. But when you have an overview of what that impact is, and I do actually have a short sort of 2-page bullet point, so I can run through that if you want me to, and we've got time at the end, but I can run through that if you want to see, if you want to pick that up as an issue. Perpetrators, it's interesting you brought perpetrators to the table. We don't deal with anything to do with perpetrators because our area of work is around the children, but what I would say is it's a conveyor belt for perpetrators. If you put safeguarding around one child, they'll just go out and find another. And I don't feel, personally, I do not feel there is enough work done to work with perpetrators. Stop It Nows and Lucy Faithfull, massive piece of work, and they're brilliant at what they do. So Stop and Safer Living and various other organisations that work with those who feel they're going to offend is incredibly valuable. But working out why people are offending, and I think the different models of offending, you know, we've heard a lot about the group offending, we've heard a lot about the online offending, but there's lots and lots of other kinds of offending done in a different setting that we don't hear about, and therefore we don't look for, we don't recognise it the same. And I do feel that there's a massive gap around understanding offending, because until we've started to tackle that issue, then we've still got this conveyor belt of children. And I do believe that one of the ways that we can tackle it is that education in schools and earlier stage about what is a healthy relationship and what is unacceptable and what is illegal with our children, so that we get in an early with that. Many of you may have taken part in some of the consultation, but Sajid Javid, when he was the health minister, approached me. I've worked with Saj for a number of years, and I was an expert panel member for his report on gang offending. I've worked with all the Home Secretaries over the time. He picked it up and carried on with this piece of work after he'd finished as Home Secretary with the Centre of Social Justice. That piece of work was, once he became Minister of Health, he came back to me and said, how do we look at health? What can we do here? So his strategic lead, his safeguarding strategic lead for health, Olivia, asked me if we could pull together some consultation sessions, which we did. I think we've spoken to over 100 different people over a period of time. And just before we were about to speak to a group, Sajid Javid resigned. And so I've got to pick it up with Olivia. I did speak to her yesterday to see if she was coming today. She was invited, but she's on annual leave. And I think we still, there's more ways of skinning a cat. When we've collected this data and we've collected this consultation, then let's look at how we can still use it. It might be recommendations from ourselves working with everybody. It may be a way that we can get into the new Minister of Health once the governance, there's no point at the moment, because once a new Prime Minister is put into place, it will be new ministers for everything. So I think whoever's minister at the moment, it's just a holding position until they've got themselves sorted out. So we'll wait for that and see if we can re-engage at that point. And hopefully Sajid Javid will pick up in another role that's significant, that we can continue to look at this. So those are kind of the big things that we're working on as a team. For those that you don't know, I don't know how many know about our team. I will just say to you, I could talk to you forever about them, but they're a very skilled team. We do not employ anybody that has not walked the walk and talked the talk first. So we have people who are specialists in transition, education, diversity and inclusion, trafficking. We've got police and justice lead. We've got safeguarding expertise. We've got working with parents and communities. We've got some really good access to send issues. What else have we got, Cheryl? Diversity and inclusion. There's a whole host of people here that if you have a problem, they're there for you to pick the phone up to. And I don't think people realise that. When you talk about moving a case on, or you've got something you're not sure what it is, you really can pick the phone up, request a space in the surgery, and it's a safe space. It goes nowhere. You don't have to give us any details about that child or the case other than gender and age, so that we've got a basis, and you can talk freely about that case, and you will get all of those people round the table that will help you to think through how you might problem solve. They'll connect you with other people that have dealt with something similar if we've got it, and that's the point of the network. And interestingly enough, this morning, somebody came onto our live chat. She's a specialist community public health nurse, in brackets school nurse, looking around for some time to find how school nurses in other trusts support sexually exploited young people. Her work is increasing in this area, and the trust she works for doesn't seem to have a lot of information, and she wonders what and how school nurses are involved in this huge piece of work, and any ideas, knowledge, plans in place, anything really that she can link into. So this is clearly somebody that's just picked this up, and this is the value of the network. So if anybody has got anything that they are doing that we can share your email address with her so that she can pick it up and have, that's the strength of this forum. You can ask us anything and we will put it out across the network if needs be, but removing who you are and anonymising that case. And then it goes out to like 14,000 dissemination points and asks if anybody's got anything similar and what they can offer, and we'll pull that together and send it back to you. So the network's yours. It's as good as you make it, and it's as good as you put into it. So I think it's really it will be valuable. There's just one bit. I'll pop this link into the chat for you, and that was I'm guessing most of you will have had it, but just in case not, the new Department of Health and Social Care guidance was published at the end of July. It highlights new guidance on health and wellbeing boards, preparation of integrated care services, and health overview and scrutiny committee panels. I'm presuming everybody's seen it, but if not, then there's the link to the guidance, and you might find it useful. It may be something that you want to pick up as an area to debate, but I think that's the next part of our agenda, isn't it, Claire? Is to say, is to have the discussion.
What I suppose what me and Sheila want to know is what you want from this forum. So I think what we've tried to do in the first half is sort of give you a bit of a flavour of what's out there nationally from Sheila and what's locally maybe driving you. But actually what we want to do is we've planned the next 4 dates, and we've made them 2 hours. And we have moved the day around as well, because we all recognise that Friday is not the greatest day in the world to do something like this. So we've moved the days of the week as well, so that it means that people who don't work Fridays or part-time can access us. But actually, I suppose what we're saying now is are there topics, you know, are there burning topics that we can build on, and you want to bring, that we can have sort of a discussion and look at relevant research and evidence, and where other areas might be doing something that we can share. I mean, I've got a few ideas, but I just thought, I wondered whether anybody wants to unmute or put something in the chat. We'd love a chat, but I recognise that some people don't like chatting. Me and Sheila love chatting, so we can just chat. But if someone wants to unmute and ask something or bring something, or would you rather just write it along in the chat? Have you got anything? I can't see the chat, Sheila, can you?
I can see the chat, yes. So Karen, do you want to unmute? You've got a question, you've got a request here, haven't you?
Yeah, and I've had some helpful responses. Hiya, I'm Karen Hedgley. I'm designated nurse for safeguarding children in North Yorkshire and York. I would say CCG, but apparently I don't work for a CCG anymore. I work for an ICB. We are grappling with this quite significantly in North Yorkshire and York. We don't have a hub in the same way that you guys have a hub. We do have an issue with exploitation. I would suggest it's probably not as significant as many other areas, but we do have an issue. We don't have any key resources really. One of the key things that we're grappling with at the moment is flagging young people's records in relevant provider organisations. We've got 9 providers across North Yorkshire, so that makes it even more complex. But flagging in primary care records and making sure that those flags are contemporaneous, that actually what we haven't got is we haven't got flags on children who are no longer deemed to be at risk, or that we haven't got flags on where they are, which is even more important. So that's the one thing that we're really grappling with. I think we fast coming to the conclusion that we're really going to need to seek some financial resource to support us with that, because largely it would be an administrative task. But it was just in case there was any nuggets of wisdom out there from anybody who has cracked that nut, and I can see a few people have, but it all seems to come back to, as always, having adequate resource.
Has anybody got anything that might help Karen out that's on the call? I think any of the requests that we've got, Karen, coming through, we will become part of the blog and everything that we do afterwards, so that it encourages people to come back and say, actually, we've got this. So if there's anything that comes after this, we will. But
Karen, we could have a conversation. Sorry, I'm just going to talk. Karen, we could have a conversation afterwards as well, if that would be useful, because actually I might be able to help you. I mean, just as a random.
Yeah.
So
yeah, that'd be good. That'd be great. Thank you. And again, thanks to everybody else. I might be coming to folks to say, right, have you got business cases to stop reinventing the wheel? We've already got a business case for something else, so I think I might just bide my time a little bit, really.
I think you're right, though. I think flagging is really important, but I think you're absolutely right that it's important that they go on, but it's important that they come off. And I think that's and that professionals understand the relevance of the flag. So there's lots there really around flagging, but certainly it was something that came up for us, but I think they need to be meaningful, and they need to be timely, and they need to go on in a timely manner, but they also really importantly need to come off.
Catch up, Claire. Thank you.
No worries.
So there's a couple of things in here. Somebody was wanting, I've lost it now, wanting to know about the impact of the pandemic. We did do quite a lot of recorded sessions on the impact of the pandemic on practitioners while they were going through it. So from they were all multidisciplinary ones, but I think, Cheryl, we could share those links to those, couldn't we, so that we could do that in the blog. So we won't put them in the chat, we'll put them in the blog so that people can go back to those, but we could we could look at that as a theme. Health's response to child exploitation and the national picture would be helpful and able to learn from the best practice. Yeah, I think we can look around. We have got some areas that have got some really good practice, and it would perhaps be useful to do. Would looking at transition be good? Would people find looking at transition really useful? Because there we've got somebody that's actually set up a bespoke service to do that, and we could ask her if she could come and talk to you all. That would be a theme if people felt that was a good theme to work from. We've got quite a lot of oh yeah, do Kath.
Thanks, Sheila. One of the areas that I'm always interested, I'm a mental health nurse by background, and prior to coming into this role, I worked on adolescent forensic services, secure inpatient services for young people who have significant mental health concerns. One of the things I found there is we'd have a lot of young people coming through who, yes, you know, there's no getting away from the, you know, that been something horrendous happened in terms of their what they've done, but always hold in mind that that child was a victim of trauma prior to this thing happening. So that was always one of my strong points, and I go to a lot of MAPA and PDP meetings, and we'll either talk about a young person or talk about an adult, and I'm always really passionate about making sure that we hear that person's story, what's led that person to this point where we are now discussing them with significant concerns. And what I see in my area is a lot of young people and adults who will slip between the, in terms of professionals' views, slip between the role of victim and perpetrator or facilitator. And I have a lot of challenging conversations with people about that in meetings. And I've just been interested to hear from colleagues around the table, the virtual table, is how we ensure that that person is still held as a victim. You know, even though they may be then going on to facilitate, maybe going on to be involved in cuckooing or trapping or whatever it is. I have a lot of challenge in my area around that. And the other thing I'd like colleagues around the table in is, although I'm a mental health nurse by background and I worked with mental health for 30 odd years prior to coming into this role, mental health are the service that I struggle to get information from. That very, you know, and we are in, myself and my designated nurse are in communication with our mental health trust to try and look at easing those pathways. So those are the two areas at the moment that are causing me to scratch my head a bit.
We did.
Thanks, Kath. That's really interesting, and actually I agree with you. I mean, I agree with you on both points, but particularly the first one. I think I was talking to someone. I went to some training which was amazing a few years ago, and it was someone who was working with young people in youth offending systems to understand their story, really, to understand why they'd ended up where they'd ended up. And you know, in so many cases it was around them being groomed or abused historically and then become a perpetrator of that. And I think it's really a valuable point that we probably need to explore, because in some ways otherwise we're never going to move on. I mean, we're learning all the time and we're gathering information, but actually fundamentally, and it's quite a tricky one, we have to understand that perpetrator journey, because otherwise how are we going to break this path that happens?
I think so, Claire, and I think as well, it kind of fits in with what yourself and Sheila was saying about language as well. So, for example, one young person I'm working with, he's an absolute delight, and I do have a soft spot for him. He is involved in county lines and criminal exploitation, and that we understand that there's been a few missing episodes, but some of the language coming back from professionals, you know, in terms of the exploitation markers, was like, this young person doesn't appear to want to change his lifestyle, and I have this, you know, obviously I challenge that obviously very, very strongly, and it's just, it's those things that I sometimes feel you know, we know about language, we know about the importance of it. It's just getting that embedded, you know, and I do think professionals come to work every day to want to do a good job. I believe that, because otherwise, you know, why would come to work? But it's just about, you know, what we can do, I guess, about raising that. And it is difficult when somebody appears to be, you know, committing crimes, and police have their role and we have our role, but still a child. And there's still grooming and exploitation there.
We could have a session on language. I think the other thing that you're talking about there, Kath, as well, is the impact of ACEs, those adverse childhood experiences. Again, there is a video YouTube piece that we did with Dr. Warren Larkin. Do any of you know Dr. Warren Larkin? Psychologist, and he does a lot around ACEs and that impact on children's vulnerabilities. And it's interesting because in Canada they've made ACEs mandatory therapeutic response, but this country's got some real reservations about, and I think that's to do with numbers. Personally, I think it's to do with demand and not being able to manage it all. So I think we could do something on ACEs if you wanted to do something on ACEs. Understanding the journey of the perpetrator. Yeah, it's a little bit outside my my network, but there are other networks where I can ask if we can have some input from, so that we can explore that. Yeah, so there's quite a number of things there that you would like to see in discussions, which is great. Which is great, because we're really sincere about, you have to feed back to us if this is not working for you, because it's got to be valuable space. You're all incredibly busy, so I think we do need to make sure that the space is well used for you all. Kath, you've got your hand up.
Sorry, I don't want to keep wittering on this and not letting other people have a voice, but the other thing I was thinking of, I'd be interested in hearing about the impact on siblings in terms of exploitation. I think that, you know, a lot of our young people, it impacts on the whole family. We all know that. I'm pushing against an open door saying that to you guys, but I'd just be interested in hearing about what people's responses are around that.
Yeah, no, I think that's valuable. That's really interesting, actually. Yeah.
Thanks for coming, Sarah. I hope you found it useful. She needs to leave early, unfortunately. She's got another meeting. So yes, we can certainly look at the impact on siblings and find somebody to talk about that. Is there anything that anybody else kind of wants to talk about? It's all gone quiet now.
I know it has. Yeah. I think the heat's getting to us all.
And a big open space, isn't it?
Sheila, I've got a question. This is Helen from Bradford. I'd be interested to know the experience of the other exploitation nurses and access to universal services to refer on to for these young people, because we have a massive issue in Bradford in that there really isn't. Shush, Imogen, I'm talking. We really don't have service. Apologies for that. We really don't have the services to refer on to in universal services. For example, like school nursing service, they have a very, very restricted remit of what they will do and what they won't do. So we're finding that there's more and more kids that we're just not able to pass on to anywhere else. They might not reach a remit for really, you know, specialist services, but they need some more lower level work, and we just don't have anywhere to send it to.
Yeah. Yeah,
I think that's a really good point, Helen. It'd be interesting to see what other people, if other people, we've got hands up everywhere now. That, Helen,
isn't it? That's great.
Yes, that's what we need.
But that might trigger a few people's responses. Yeah.
And thank you, Imogen, as well. Who should we go to first, Sheila? Are you going to manage it or am I?
You manage it, that's fine.
Okay, Gemma, I don't know who was first. Was it you? Gemma, you're right in front of me.
Bless you, thank you. So hi everybody, I'm Gemma Cross, I'm Head of Safeguarding in Lincolnshire. So I was just writing in the chat, it was really interesting that you literally asked the question that I was typing. So we don't have a school nursing service in Lincolnshire, so there is no universal health provider. It was decommissioned. No, we don't have anything. So it was decommissioned by the local authority when health visiting and school nursing transferred over to, so we've not had school nursing for 5 years. And yes, I know as a passionate school nurse background, it breaks my heart. But so that is a big risk for us. So it's it's where's NY, North Yorkshire. So yeah, I suppose that's what I was hoping to get out of here. And then the other thing that I wanted to ask about was the child exploitation sort of risk assessment that that practitioners have to use in Lincolnshire to refer into a MACE process is massive. So ours is a huge document that our partnership has developed, which isn't really conducive to an A&E or an ED type environment, urgent care. And so we were looking at trying to develop something that can evidence a level of risk that then can go into social care for social care to pick up, because obviously if you're a 15-year-old that's been trafficked and raped or smuggling drugs, you're not going to sit in a busy ED and disclose all of that when everything else is going off. So they were the two things, and I know we probably won't pick those up today, but yeah, I'd be interested to see if anybody's got any shorter risk assessments that are maybe just being used by health. But yeah, anything we can do to get a universal service of some sort for.
Don't know what to say about that, but anyway, that's really good information and they're really good questions. So I don't know whether
just bob in there. What we could do there, Gemma, is ask anybody that's on here that's got a risk assessment for their area to send us a blank one, and we could put them all together on our website so that maybe you might be able to kind of juggle something and make one that's a bit more focused between us. And
everybody might find that really useful.
Yeah. So if you have a risk assessment that's specific to your area, please email it us in, and then we'll put them all together, and it may be a little subgroup that maybe wants to work on making something that's more relevant, tighter, easier to manage. That's the value. You may well find something that's perfect that somebody else is doing that just needs a slight tweak. So somebody said they've got the same regarding screening tools. Oh, 3 different schools. It's 3 different tools in your. Yeah, well, this is the perfect time to collaborate and try and do something together if that's what everybody wants to do. Next one then.
Okay, sure. Catherine, are you happy to talk next? Catherine?
Sorry, I forgot my hand was stood up. Yeah, so I was just, I put my hand up after the conversation about universal services, really. And I think it's probably true for all of us that our school health services have been utterly decimated across the whole country, and are utterly under-resourced and underfunded, which leaves that universal level really difficult to cover. As I said earlier in the chat, we've got quite a good offer really across the whole of Greater Manchester. I work for the City of Manchester, and I've been in post for a long time now. It's nearly 9 years, so I've kind of had time to build up relationships and things. But there seems to we're very fortunate in having quite a good response from our local authority, and we've got things like we have a project running from our ED, which is essentially offering a youth work provision to anyone who attends ED with any sort of knife-related incident or a serious assault type incident, that they can go in and do some early intervention around things around serious youth violence. And often there's that connectivity between serious youth violence and child criminal exploitation. So we're really lucky to have that. The other thing that we've got that's really, really helpful is within our sexual health service, we have outreach nurses, but we also have outreach non-clinical workers who can go out and do targeted work around healthy relationships, online safety, and some basic sexual health work. And they will do that one-to-one or in groups, or, you know, they'll see a kid in McDonald's if that's the place that they're going to be most likely to engage. So I have got a little bit more that I can go to outside of our school nursing service. But just after a lot of years of work and a background as a school nurse as well, our school nurse colleagues are doing their utmost best to support as much as they can. They're just in an absolute bind with an underfunded service.
In Gemma's case, none at all. And that, I mean, that's the problem, and I think Helen was right to raise this because it's clearly made people think about it. Because actually, if you've got a young person who's hitting the criteria to access the specialist services, but they have some public health kind of health issue that doesn't need to be done by them, but could be done by a school nurse service, for instance, but there isn't one. There isn't. So I think it's really interesting that actually a few people are saying this. Helen Miller.
In the consultation that we did with Olivia, we came across a number of school nurses, and one talked of being the school nurse for 4 schools where there was more than 2,000 pupils in each school. And you just think of that time spread. It's an impossible task, isn't it?
It is. Yeah, it is. Yeah, it is. Helen, do you want to ask a question or comment?
Hi, yes, thank you. This is my first time involved in this kind of meeting. I was given information via Katie Vaughan, who's sadly she's just moved on actually, child sexual exploitation nurse. So I'm team leader for integrated sexual health in Nuneaton. We're commissioned by George Eliot Hospital and we cover the whole county of Warwickshire, but at the moment we're based in 3 different areas. That is soon to change with a service review that's going on. So a couple of things just to say. What I did, I spent 8 years as a school nurse. I ended up leaving when they removed the sexual health element to school nursing. It was decommissioned as part of their remit, and I'd done sexual health prior to that. I've done sexual health for 17 years. As well as, you know, nearly 40 years of nursing, a lot acute. And I was absolutely devastated when they removed that, because to me, it is such a huge part of school nursing, and all our one-to-one stopped. So yeah, I will get on the back of the fact that I think it's incredibly sad what the outcome for school nursing. But just to pick up on a few things, one of the things I was going to say was around, we had developed a vulnerability assessment for our service a few years ago. We based it on the BASH spotting the signs, and I was really pleased to hear you say, Sheila, that we're going to look at, because one of the things I want to do is make sure that we're actually asking all the right questions. And so to have a pool and try and come up with what is the best across the country would be fabulous. And I think that's, you know, that's great. Music to my ears. And also, you know, we're at a point where our service is undergoing a review. There's going to be massive changes. So again, Catherine, hearing about your outreach work, because I think that is the area where we do work really, really well, and we're improving. We didn't do very well, I don't think, and we're getting better. And we've developed fabulous links between the CSE social workers, you know, lots of different people, missing persons, social worker, the nurse, and they're directly referring into our service, getting rid of all the barriers that might have been there to make sure that we absolutely prioritise these young people. But to look at different ways we can address it as well. So again, I'd be very keen to hear that from my speciality. Thank you, and I'm very excited about this meeting. It's wonderful.
Oh, thank you, thank you. I think we've still got Louise, haven't we?
Interesting.
Yeah.
Thank you very much. I'm currently doing an assistant designated nurse for safeguarding role within Black Country, West Birmingham ICB, but prior to that I was named nurse for safeguarding children in Birmingham and was very heavily involved in the sort of exploitation work there. I'm really keen, as one of our criteria, and this was all instigated by Helen's points really, is to try and understand the health response. We've seen a lot of meetings discussing risk and discussing these children and what can we do to try and stop and disrupt. But the health response is really, really weak. And I'm a school nurse by background and also feel passionate about school nursing. I did an audit in Birmingham and of 230 safeguarding exploitation referrals that came in 1 month, 64% of those children had got either diagnosed or undiagnosed health needs. A lot of neurodevelopmental concerns for these children and young people. So I'd be maybe quite keen to try and include that in any work that we do going forward and trying to see a connection, because the universal work is absolutely essential. It's the way forward, isn't it? Thank you.
Thanks, Louise.
You're almost picking your next theme, aren't you? It seems to be those universal services. That seems to be the theme for the next meeting. Would you say? Would that meet with people's approval? Perhaps a bit of a hands up if you think that that's the right subject. I got 2 or 3 there. Some people haven't got the cameras on, so maybe if you could indicate.
There's lots of thumbs up though. I quite like those floating thumbs.
Lots of thumbs up. So
lots of floating thumbs.
And we'll try and make it as diverse as we can. We'll give some thought to it and probably ask a number of you to come and just do a few minutes of what you do in your area. And then break out, and so I think we've got our next theme, which is fantastic, isn't it?
Brilliant. Yeah, it is. That's been a really, really interesting discussion actually, because I think what we've learned is that, and which doesn't surprise me, is that we all have very similar themes. So actually, it'll be really, really useful to be able to learn from each other about what maybe works well in your service or your area, and maybe what you need to learn from other areas that you can sort of drag, borrow, steal.
Can I just ask a bit of a fundamental question? How many of you that are on the call today are actually fully paid up members? Can you just perhaps put a thumbs up if you are, if you're not? No. So there is on our yes. So one is, yeah, that's interesting, isn't it? There is a tile on our website which is health only. So we limited this meeting to health professionals only, so that it remained a health focus and wasn't diverted by other people attending. And when we released it, advertised it, the very first person that signed up for it was a social worker. And we had to go back and say, no, we're just making this health. And we do the same with the police one. We make it a very, very safe space. So whatever you want to put, if we're talking about something in the recording that we do not want in a public domain and we want to keep it as a safe space to speak, we'll stop the recording at that point and start again, so that you have got that space. But the website is limited to members. Now you can be a member for just £50 and you can have 25 people in that membership. So that membership gives you a reduction in all of our training programs. It gives you a reduction at the national conference that we host. It gives you access to about 16,000 resources that are in there. Some are public resources, but not all of them. Things like the benchmarking tool for parents as valuable safeguarding partners, are the disruption toolkit. It's all in our membership side. So this isn't me touting for membership. It's just trying to explain how we as an organisation work. We don't make everything public because we think if we make everything public, we're giving it to offenders and they know how to work around it all. So we have this membership side, but we also have to keep, we are a charity, and almost everything we do free of charge. and that's one way of keeping our website up to date more than anything else. So I'll get Cheryl to pop the website address in to the chat so that you can go and have a look, and also a bit about the benefits of being a member, if you can at all get a commissioner to make you a member. And like I say, you can be a member for 50 quid, but it's up to you guys. It's just that all the recordings and everything will be in the membership site, which might make it a bit more difficult for some of you to access. So I hope that doesn't put a dampener on things for people. The email online forum that we'll develop that underpins this will remain free of charge anyway. And if you can't get your membership, you can paid for, you can access a lot of it by being a free member. So, you know, don't not become a member. Just go through that process and just put a public member, so there you can access some of them. So yes, so what have we got else here?
Have we got anything? Helen, have you raised your hand again? No, it must be a legacy hand. Anybody else want to say anything before we, don't know what time wise where we are?
We've got about 10 minutes.
Okay.
So
anything else? Anybody else want to raise anything that potentially they would like us to think about for the, if we think about, we've got, it looks like a session set for next time, but then we've already got booked the 4 sessions over the next year. So I'm not to be decided today either as well, I guess, is to think about when we come back to the next session, what we might want for the following one, so that we can just sort of stay abreast of what's going on.
I wonder whether we ask Catherine and Helen if at the next meeting they just want to do a sort of 15-minute presentation on the work that they do around universal services. Would that be useful to hear from some areas where it's working well? Would you feel comfortable with that, Catherine?
Fine, provided I'm free for the next.
Yes.
Session.
Yes.
And Helen, I know you got pulled away a little bit there. We were just wondering whether we might benefit from hearing about your universal services for about 15 minutes at the next meeting.
Sorry, is that Helen Miller you were talking to?
Yeah,
sorry,
it's you. Yeah.
And ask me something. Yeah, yes, very happy to look at that.
So it would be really helpful to have a database of health practitioners working in CE kept somewhere centrally. Well, let us work with that one. The forum, sorry. Yeah, so she's Cheryl's just popping the link on for the next forum meeting so that you've got it. So if you're free, you can pop a booking into that. I'll have a conversation here with Cheryl about something about a database, because it needs to be more than just names, doesn't it? It actually needs to be a little bit about your role and what you're covering, so that so we'll work on that one. We'll just have a little play between Claire and Cheryl and myself about what we might be able to put together, and where we might keep it, because my feeling is that we'd have to keep that in our membership because of the GDPR aspects of it. But let me know how we go. Right, anything else?
Anything else, anybody, for the first health forum?
May I ask, has the first health forum kind of been what you wanted it to be? Do you feel it's heading in the right direction, or do you think we've got something wrong? Because this is, we're not precious about being told you've got it wrong.
Absolutely not. That's how we learn. It's absolutely
it's fine. How we learn. Do you think it's shaping up how you might like it to be? the
and we
sun
can
rods.
build, you know, I think we can build on it, can't we? I think what
good.
we've got is people around us we're all interested in the same thing, and we all want to deliver a good service, and we've all got lots of skills and expertise, clearly. So actually, if we can share all that and take that back out to where we are, that sounds a really positive experience for us all.
Karen's just asking Claire if you can stay on at the end, just.
I can't hear you, Sheila, you're on mute.
Most people seem to think it's worked really well. It will grow. The more health professionals we get into this meeting and breaking out into discussion groups where you'll get lots and lots of different strands to the conversation and making sure that everybody has notes from them, I feel sure it will grow. Friday's a difficult day. I don't know how many we've had in today. So we had 24 at one point. So out of 68 who'd booked on, we have another one just joining us right at the last moment. But I think that's a Friday, and that's the nature of your work. We recognise it's the nature of your work that you can't always go to where you want to go to. So personally, I'd thank you all massively for taking the time out. I think it's got lots of value. This is exactly what I've been looking for as a new named nurse.
Brilliant, brilliant. That's fantastic. Because that's what we want. We just want to, you know, help and support and make health really important.
Brilliant. So thank you all very much for your time. Claire, I was delighted when Claire said that she'd jointly chair it with me, because whilst I know quite a lot around the exploitation of children, I'm really not versed at all in health structures and terminology and all sorts of things. So I needed a backup. So I'm really grateful for Claire to spare the time. And just at that last moment, our Cheryl's popped her head in. Cheryl is she's our network coordinator. So if you've got any queries about membership, then do contact either myself or Claire. So great. Thanks ever so much. Have a fab weekend. Don't burn, but enjoy the sun.
Yeah, enjoy the sunshine.
Take care.
Look after yourself, guys.
Bye.
Thanks, everyone. Bye.
Bye. Bye.